Welcome, everyone. We've got a number of participants online live, and I'm very pleased this morning that we have my friend and colleague, Dr. Alex Filatenkov, who's a breast pathologist and one of our faculty at the University of Oklahoma. Had his training in breast pathology in Texas, and is a wonderful colleague and amateur gardener, farmer, baker.
Actually, not that amateur. I actually sell my produce on farm markets. I'm actually
Okay,
kind of
okay,
a
there you go.
professional.
All right, so he's
You move in more in
avocation.
the professional area.
So we're pleased to have him to share some cases in breast pathology. And Alex, the platform is yours. You can share your screen as you choose and lead us through that. As we go along, if people have questions, please feel free to enter those into the chat, and we'll take some time at the end to go through those. So, Alex,
Well, yeah, I
away.
actually would like to make it more interactive so people actually are gonna ask questions and people uh should I ask questions what to do because those cases actually as we get them, we have cancer center which is NIH designated and also the only nationally accredited center for breast cancers in the state. So we have very, very interesting and cases that are not straightforward. So I show you some, and I will be asking questions.
Okay, so let's make this as interactive as possible,
It's,
folks. Don't
I
be
mean,
afraid to
you
speak
don't
up.
have to, but I mean, it's more like how would you approach the case rather than what it is? Because sometimes it's really hard to say what it is right away. It requires lots of steps to figure out what's going on. It's not that you know anything. You approach the case, you don't know anything. You need to figure that out. It's not, it's always like a puzzle you need to solve. So it's not like, oh, I know what it is. No, it's not the way it works. You need to kind of figure out what's going on. So, and sometimes it requires a lot of additional steps. Let's just hang out. And this first case kind of just interesting and more like how would they approach this biopsy? Let me see. Let me see what's going on here. So, all right. So it's just biopsy comes in. I won't tell you much of history intentionally. So you got a piece of skin, punch biopsy. Can you guys see? Can you see me? Can you see the
Yeah,
screen?
yeah,
Everybody
the
can
screen's
see?
visible. Yeah.
All right. So here's a skin biopsy. Here's a lesion. I won't tell you history intentionally first, but what do you guys think? Here's the skin, here's the lesion, and what will be your first impression? And most importantly, what stains would you do to figure that out? It's a breast skin and punch biopsy. There was some skin lesion, and uh, what would you do when you see something like that?
What do you think, Dr. Huff? What would you say?
Hello? Yeah, I see these irregular infiltrated nets are called atypical cells. And
Yeah,
I would like to figure out, uh, uh, I mean, apparently it's normal to be present over there because in the skin, we should only see some skin collagen or fibroblast. So this cell population definitely is abnormal. So now we need to figure out, are they cancer cells and what kind of cancer cells?
yeah. So what stain would you do?
Because it's under the
Okay,
skin.
I'll
I
tell
mean,
you,
the differential could,
patient has history of invasive ductal carcinoma in the past. And and this is the skin, and that patient was treated.
considering history, so we should always consider the recurrence of the cancer.
Recurrence cancer, so yeah, and what was the most important thing you do right away?
Yeah, the Panther K is the one we definitely
Yeah,
need.
yeah, that's what I wanted actually to emphasize. It's cancer, history of invasive ductal carcinoma. It was treated, and we let me um first thing you would do is pancake. Actually, yesterday was preparing it. Where's my pancake? Here. Okay, here. Okay, let's look at pancake. Here's the skin. So what do you think?
Okay, this
Right? You can
can you
see.
move around? Can you move around a little bit? Because I feel like this pancake only highlights the sweat gland or the
Yeah,
negative gland. It
nine
didn't
glands. So
highlight those
first,
tumor cells.
that is the most important stain. So it's less likely recurrent carcinoma. And since patients have a history of carcinoma, what's your next? And let's look CK7 just for fun. It's
Do we have a CD68? I thought they were histiocytes morphologically.
it's a good question. Yeah, I don't think I ordered 68, and I
But
don't have
they're
it.
clearly not epithelial because pan-CK is negative.
Yeah, so first of all, Pansy is CK7 negative. So it's already,
Yeah,
and also, since it's a press service, we did all the things. We did GATA3
yeah.
and ERPR. This workup applies to many breast lesions. It's not just for that one. When you see some high-grade lesion or funny lesion, it's always good idea to invest time and PAN-CK is one of the most important things in breast pathology, especially in tumors which may look like triple negative tumor or some funny lesion. Doing PAN-CK will help you narrow down and really help you with your differential right away. It will immediately knock out vascular lesions, melanomas,
Mm.
some weird hematologic lymphomas and also plasmacytomas and all those things actually absorb see all the time. So Pansy is the most common stain, and this tumor is triple negative. If you don't do Pansy, and again, this workup applies to many things. For example, it's not uncommon to have metastatic melanoma in axillary area, and you may actually misdiagnose it as a triple negative breast cancer if you don't do Pansy. So doing Pansy in this scenario is very helpful. But again, considering the history of uh, cancer, breast cancer, what else would you suspect? Since we already determined,
Can we go on high power and see the morphology? I really want to see the morphology of the cells.
yeah,
Thank you.
we already determined that this is not likely to be carcinoma, considering
Hmm.
it's keratin
Yeah,
negative,
pan-CK negative. Yeah.
negative, uh, and
Could this be angiosarcoma, Alex? We have vascular
yeah.
lesion. Maybe it's
So this is the thing, but again, biopsy is very small.
Yeah.
We discussed it also during metapathology. We found only one mitosis. But again, yeah, this since patient had actually history of tumor and they don't explicitly say had radiation, but you can that's something you would suspect. And then you perform stains, vascular stains, and you can see that lesion is this is CD31, right?
Positive.
The vascular origin, and then U240 is actually negative. But CD31 is positive, and the problem of of this biopsy is that it's very small and very limited, and morphologically, we only found one mitosis. It's definitely atypical, so you can really make a diagnosis of angiosarcoma on that biopsy. So differential diagnosis includes, of course, it can be angiosarcoma, but can also be a typical vascular lesion, which
Mm.
is not angiosarcoma, but it's definitely a typical result of radiation. It's always only limited to skin. So eventually, what we would do when approach case like that, you don't diagnose angiosarcoma of this small biopsy, but you say it's a typical vascular proliferation, and differential includes typical vascular lesion or angiosarcoma and recommend excision. So the whole idea why I showed it to you, when approach cases, when you see something, if keratin is one of the most important states, so allows you to knock out really with your differential, so if you know it's not carcinoma, and it is several keratins, they do breast profile, and since it's doesn't look, it may look epithelioid, and again, it will help you with other cases when you have melanomas, when you have lymphomas, whenever you have some strange mesenchymal proliferations. So keratin was stays in this scenario. So the message is that, but you don't diagnose angiosarcoma. It may be angiosarcoma, and we recommend excision, but you just say give a differential, say typical vascular proliferation. Differential includes atypical vascular lesion or angiosarcoma, and excision recommended, and then final characterization. And you have more tissue, then you can do additional tests. But that's kind of the way you approach. That's what I wanted to show you. Okay, let's talk about another interesting case, which is this actually a resection, but biopsy showed, I don't know biopsy, but biopsy showed a typical apocrine proliferation that was difficult to characterize in biopsy. It was itself with apocrine morphology, but kind of a little more typical than typical regular apocrine adenosis. Or I mean, it was looked more typical than apocrine metaplasia. In those cases, are very difficult because there's apocrine metaplasias and there's a typical apocrine adenosis can be atypical apocrine adenosis. Then differential includes DCIS with apocrine features, and sometimes very hard to distinguish and make a diagnosis in biopsy. So when you see atypical apocrine proliferation, recommend excision to characterize the lesion further. And let's look what we got. And this is a really cool case because it includes lots of interesting borderline lesion, the concepts. So that's what we, let me show you. Yeah. So that's what we got on larger lesion. That's what we got on excision. So as you can see, this is circumscribed lesion, looks like in situ lesion, and also has apocrine features, some cribriforming. And the problem with this lesion, again, apocrine metaplasia can give you this cribriform look, especially when it involves other entities like intraductal papilloma or some UDH. When apocrine metaplasia involves those lesions, can give this cribriforming appearance, which can kind of confuse you. Is it actual atypia or not? And that's what we got on this biopsy. I show you just for fun. Similar in the same biopsy, that lesion. So this is first one I showed you the main lesion, and I show you that guy. That one, also apocrine. I just want you kind of have an idea. Look at that guy and look at the main lesion, which was biopsy. So, and again, what would you do first to figure out what's going on here?
Dr. Akshay, do you want to put your ideas out there?
Okay, your differential should be, of course, apocrine metaplasia, a typical apocrine adenosis. It can be, since you see there's some papillary infrastructure there, it can be papilloma involved either by apocrine metaplasia or by atypical process like ADH or DCIS with apocrine features. It can be just outright papillary DCIS with apocrine features, or it can be also entities like encapsulated papillary carcinoma, which can look circumscribed, but it lacks myepithelial cells. So what would you do as a first stain, few set of stains, and I would guide you, how would your differential change? Buddy? All right. Since first thing, since talking about it sit inside a lesion, first thing is P63. But you need to figure out what's going on. Is it P63 will help you narrow down, is it papillomastosis or is it pre-existing process like intraductal papilloma involved by something? So P63 is very, very cool here. You can see that this is all P63 is present on those fibrovascular cores. So that's immediately, and this is adenosis, which involves by atypical cells here. And then you can see those entities, they have P63 not only surrounding them, but also P63 inside. That is a very, very important concept when you approach any kind of papillary lesions of the breast. Again, a papillary lesion of the breast is the most difficult area. And P63 also, let's look at CK56, kind of same deal. Let me show you. CK56, same deal. CK56 shows mosaic, sort of mosaic pattern of those inside of those entities surrounding them and also inside fibrosing core. So this already immediately narrows to the differential. It means there's intraductal papilloma. This preserved architecture P63 CK56 preserved in those fibrosing cores. So we already determined that it is less likely papillary DCS to start with. That's definitely papilloma was there, which is colonized by something. And what it is. So I showed you this two entities on purpose. First one actually are my main lesion. You can see those cells and look at the cells in the lesion. They are atypical. But again, what it is it apocrine metaplasia or is it atypical apocrine adenosis or it's apocrine DCIS? We already know that there is papilloma there involved by something. But you see, even here, cells are atypical. They're not normal cells. And if you carefully look, there's these areas of cribriforming, monotony. So it's definitely not, it's not, and let's take in the same specimen, actual regular garden variety apocrine metaplasia. Here's a, I want to look at this. This is apocrine metaplasia. And you see how different it is? Apocrine metaplasia, very, very different from the lesion which was biopsied. Here's apocrine metaplasia. So most important stain here, so what do you think? Again, let's look at CK56. CK56 is known, it not only highlights fibrovascular cores, but it also absent the lectin in entities like DCIS is attenuated, and entities like DCIS or ADH, it will be attenuated. And I want to look at CK56 again. Also, it highlights those fibrovascular cores, those areas. In these areas, it's missing. So, see those areas? And okay, most important thing next is estrogen receptor, because it's known, I've never seen ever apocrine metaplasia to be ER positive. However, ADH, low-grade ADH, DCIS, low-grade DCIS will have monotonous strong ER staining. Now, also, to rule out, we already established this in intraductal papilloma colonized by something. You also need to do e-adherent to make sure it's not lobar carcinoma inside or ALH involving that entity. You can see e-adherent is preserved, so it's not lobar carcinoma. But it also highlights this cribriform architecture is very, very worrisome. for ADH or DCIS. However, we know already this is not Pepper DCIS because fibrovascular cores are preserved, which was proven by P63-56 staining. But this e-coherence analysis shows you this rigid architecture. And the most important thing here is estrogen and progesterone receptors, because an upper will be, let me find you, show you really good example of ER staining, NPR. So here our ER staining, that's where money is. If you can see, the entity is strongly monotonous, shows strong monotonous ER staining. And with the PR, same thing. And let's look at the, for example, find benign glands, which show, for example, benign glands show wild type staining. However, the lesion show monotonous strong ER staining is strong PR staining. And I was showing you this apocrine metaplasia before in a different section. Let's look at ER. I have one. Oh, I don't think I did it. But anyways, since we did full workup, we established first that this is atypical, cells atypical. However, P63 CKF6 preserved, so this is papilloma. However, it was involved by a lesion that has attenuated CK56 and strong monotonous ERPR staining. So this is ductal carcinoma in situ with apocrine features that involves intraductal papilloma. So, and that's how you approach those lesions. That's a whole workup, and it covers many, many concepts. And again, if it was apocrine metaplasia, it would be R negative, or even atypical apocrine kind of gray zone, weird entity. It can be also ER attenuated. However, this is strong PR monotonous staining, which is on the cornerstone of the diagnosis, and also CK56 is attenuated in those cribriform lesions. So this is DCIS involving diarrheal papilloma. So that's kind of fun case. Okay, let's look at more things. This next case is also super cool. This is really wild. So we have 22-year-old patient, and that's what going on here. 22-year-old. So that's a lesion you have. So any ideas? What is that? 22-year-old. Any?
Very cellular and spindle cell like in the
Yeah. So you see,
pleomorphic
it is very
nuclei.
funny, right? It looks more like mesenchymal neoplasm. Very, very pleomorphic, very cellular, very spindle, mesenchymal looking neoplasm, pleomorphic. Again, and let's look higher. You see how crazy those cells are, and not normal, right? And doesn't look epithelioid at all. You see those large cells. And what would be your differential?
Differential, unfortunately, has to be malignancy, either metaplastic versus some stroma sarcoma. And
Yeah.
so
So morphology is very suspicious for some sort of mesenchymal neoplasm. Also, it can be phyllodes. Malignant phyllodes is actually it's a sarcoma. And again, as we always talk, first thing we do is ferritin, right? So make sure is it for metaplastic carcinoma, it can have different forms. It can have spindle, it can have like cartilage matrix formation, but in all, you always need to find some sort of keratin staining to call it metaplastic carcinoma. And the first thing we did, look at keratin. So you think? There's positivity. Well, multiple cells. It's not it's actually pretty good staining. So it is. It shows keratin positivity. So it already gives you an idea. This probably differential is already kind of supports the idea of metaplastic carcinoma. Also, just for fun, let's look at CK7. For metaplastic, you need to do a whole panel of keratins because it can be weak expression. Not every keratin will be positive, and pan-CK is very good. For example, CK7, you can see negative, but you need to run a panel of keratins, not just one, and then pick up. I did a bunch of them, and we can see pan-CK is very positive. Let's look at CK56. Again, there's some cells, some weak positivity here and there. But again, not very strong, but there's some positive cells in there, very weak. However, here's some cell positive. Again, it's okay, it's enough. But what is this most important? What's a very, very helpful stain for metaplastic? What stain would really help you with metaplastic carcinoma? Okay, one of the most important stain for metaplastic is P63. Again, in breast pathology, there's no really particular test you really can make. It's all like kind of supportive tests that can be negative, and you put all things together. You already established keratin positivity. And this is a very important stain. P63 is very important for metaplastic carcinoma. It's very helpful to diagnose it because you can see P63 is positive, convincingly positive in the spindle cell neoplasm. So it already gives you lots of supportive evidence that it is most likely it's a epithelioid, it's carcinoma, it's less likely some sort of sarcoma, pan-CK, some CK7 positivity, and most important P63 positivity. So it's very, very, very supportive of metaplastic tumor. And let's look at GATA. I think I had GATA here. I actually don't remember what it was. GATA is very helpful. It also like a breast origin. There's some GATA positivity, very weak. Here and there, some cells are positive for GATA. So this is also very good. It's all supportive idea of metaplastic breast. You see, there's some GATA positivity, and it's happens as some weak, but there are positive cells here and there. And GATA, so more and more evidence towards metaplastic carcinoma. And I show you PI. Let's look PI. Yeah. And I did all melanoma stains and all this other stains which are negative. SOX10 can be helpful in triple negative. SOX10 is not negative. But and again, and to call it metaplastic, and also to rule out any kind of rhabdomyosarcoma, sarcoma, so things of that nature. We did for things like Bestman, all negative. Desmin, so it's less likely because in this young patients, you can have strange entities like other rhabdomyosarcoma, and we had it actually metastatic into breast. So, but there's definitely keratin positive and it's Desmin negative, myogenic negative. So it's not some sort of, and the eye is is rather high, as you can see. So rather high here, so high grade. And to complete the picture, you need to do, of course, breast panel. And breast panel was, let me show you ER. ER. Where's my ER? Sorry, let me show you. Here's ER. See, R is negative. And here too was negative and PR. PR has showed some positivity actually. Weak, low positive PR, which is actually helping sometimes. Some positivity is actually also helpful, supports breast. It's not negative. So ER negative, PR weakly positive, maybe under 10% it happens. HER2 is technically almost like triple negative tumor. But again, that's 22-year-old with metaplastic carcinoma. It's triple negative, but keratin's are positive, PC3 is positive, GATA3 actually also positive. So this is a very difficult case, but this is what it is. And this 22-year-old with this spindle cell looking metaplastic tumor. But we need to do extensive workup to make sure it's not any kind of like rhabdomyosarcoma or something, or melanoma, or some sort of vascular tumor, lymphoid, lymphoma. I've seen lymphomas, I've seen plasmacytomas in the breast. And again, keratin help you, P63, and GATA is there. So this is a very cool case of metaplastic breast. Okay, let's look at the more fun stuff. Well, this is a very, very difficult case and also interesting concept. So here the patient showed up outside biopsy. That's how it looks in the biopsy. That's actually a case still being worked up. It's with its resection, it's still in the provide. I'll show you what's it. So, what do you guys think when you see something like that in a biopsy? How does it look to you?
Irregular contour of cluster of glands.
Yeah, I mean, actually, it looks like a garden variety IDC actually on this. You see this actually moderately differentiated or well differentiated, even you see those glands. It's definitely infiltrative pattern. So yeah, it's probably morphologically most likely when you see something like that, a low grade, at least this is probably even grade 1 IDC, right, on biopsy. That's all you can say. But what was the funny in biopsy, which is really unusual, okay, when you look at the ER, here, ER, anybody has a problem with that? There's a tumor there. This is ER. Anybody has a problem that ER is negative and that PR is negative too, L2 is negative, internal controls are there. Let me look at the KI. Yeah, it's not that. There's some PI positivity, but maybe 15%. But again, does it look like, is that morphology? Triple negative. Does anything that makes sense? Problem is that when you see something like that, it's very, very dangerous to diagnose triple negative cancer. It's definitely this for the concept I want to emphasize, discordance between low-grade morphology and receptor status. And also it's look low-grade PIs, maybe 15%, but it's triple negative. And the internal controls for ER working, so it's not like lab artifact. So when you see something like that, you need to be very, very suspicious for, you don't call it triple negative right away. Mention that morphology and receptor status is discordant, and you need to characterize the lesion on excision. So we recommend it, so they do excision. It's actually, that's what we got here. Here's the better one. Here's their tumor. Here's how tumor looks. Again, what do you think? What is what do you think when you see tumor like that? Doesn't look overtly high grade, especially those areas. Is more tumor. This infiltrative morphology with those glands. It's definitely doesn't really fit. It doesn't look like real triple negative, high grade triple negative carcinoma. Let's look at the stains. It's still triple negative. However, for example, let's look at KI. KI. Let's look at the KI. The KI is not very, it's not very wild. It's maybe 15%, 20%. It doesn't fit again for to be also it's triple negative. It's not like doesn't look like high grade triple negative carcinoma. And also we did P53, which is wild type. So our morphologically, so our differential diagnosis is it's look like a salivary gland type of neoplasm, which is includes, of course, I don't know, cystic carcinoma, and since morphology, a little funny, basaloid, we inclined to think basaloid variant. Also, there's some like a matrix formation, all like this funny, but again, it can be associated with solid, um, uh, solid uh, variant of solid basaloid variant of adenosis carcinoma, and via immunostains, you need to show dual cell population. So you do P63, CK7. P63 is actually very weak and stains some of the cells. Some scattered cells are positive P63 in this lesion. CK7 also shows some stent, and TKIT is not very helpful. So solid variant, as a solid basaloid variant of aneurystic may lack P63. So those cases are very, very difficult because you need to be very careful to distinguish between true, real triple negative carcinoma and all those lower grade triple negative entities. So right now we actually waiting for MIB and F1 translocation, which would help us. But for now, our differential, we inclined to think it's more likely represents solid basaloid variant of adenosis carcinoma. Again, in breast pathology, you have those cases which don't really fit criteria. Immunostains don't really convincingly show dual cell population. However, Ki67 and P53 staining do not support really high grade, in morphology, of course, really triple negative tumor. And this is very important to show it because it will guide the treatment. It may not necessarily need, if it's adenoid carcinoma, it may not require systemic chemotherapy because it won't respond with this low KI. And treatment for adenoid cystic carcinoma is excision and local radiation. If you give chemotherapy, it actually won't work. So you need to be very, very careful of those cases. So right now we're waiting for this molecular test back, and our top differential diagnosis, it's solid basaloid variant of adenoid carcinoma. So that's one of the quite a case. I need to make a call. So I don't really not calling this traditional triple negative carcinoma. But I need to be very suspicious when you see discordance between morphology and receptor status right away. So you need to be very, very careful here. Okay, so let's look at the fun case. They're all fun, but this one is particularly fun. You can go on and on and on. Now, let me, it depends on the time. So we have time, right, Dr. Hassel?
Yeah, I think we have time for one more.
One more. I have way more, but okay,
Wow, we have to do it.
okay, let's do this one because it can go on and on and on. This is literally in our center, we can have like, if it's in the week, those bizarre cases, one after another. We have very few straightforward cases. Okay, this is a fun case. Um, this is wild, actually. Yeah. I mean, it's really nice. So you got the case like that, so that's what you see. Yeah. So what do you think when you see something like that? Anybody? So this guy. Oh, and this actually involves some of the noses. Well, yeah, when you see like that, you think LCIS, right? And classic type LCIS. I show you there's a reason why I'm showing you this. So this, I'm going to show you ECAT hearing for 1A LCIS. On. Let's see this entity. Here, you can see ECAT hearing attenuated in here, and P120 will be here too. You can see this is the nose is colonized by LCIS. P120 will be cytoplasmic. Okay, not a big deal. And if you look at the ER, I'll show you, there is a reason I'm showing you this. If you look at the ER, where's the ER? Yeah, here, ER for that entity, LCIS, classic type, who cares? Yeah, ER is here, you see? ER positive, LCIS classic type. And see, it expands those, you could hear negative, you want to be cytoplasmic. Fun, okay, good. Look at the second part. This is where fun starts. Here, you have here more LCIS with pagetoid spread, all good stuff. Normal. But then you see that. A lot going on. What do you think? What is that? Oops, camera crashed. Let me revive my camera. But any ideas what it might be? That big guy? Let me just revive the camera and show you. So those cases require excessive workup. Okay, we got it up and running. Okay, so that looks real wild, and it looks like high-grade DCIS, right? You have this comedonecrosis. Necrosis. He is like very, very characteristic for DCIS. Lots of inflammation. but cells still look a little funny. Yeah. Also, and the funny thing that this entity can be by itself and diagnosed as high-grade DCIS, sometimes with associated conservation of lobules can confuse like invasive carcinoma. However, if you look at P63, just let's look P63 first. There's P63, 1B. So look at the whole thing. We have LCIS we already established in that area. And these guys, so here's LCIS. It's all inside, of course. And let's look at this wild high-grade inside lesion. It's also all inside. The P63 is preserved. So this is inside. Again, the problem will happen when a lesion like that colonizes adenosis or colonizes lobules. But again, but initially you would think that this is LCIS classic type plus high-grade DCIS. The problem here is if you do ecadherin, and that's the very important message here. When you see high-grade DCIS, it's always good idea still throw ecadherin, and it happens quite often. Use ecadherin. And if you look at our garden variety LCIS here, you see our classic type LCIS is ecadherin negative. Here's ecadherin negative. This is our classic type ACIS guy. And let's look at this big high grade thing. And paradoxically, something which looks like DCIS, it completely lacks ecadherin too. So the whole thing, which looks like high-grade DCIS with common necrosis, actually LCIS here. And also, see, this is, but it's very different morphologically. And there's an entity, pleomorphic LCIS. And what's really cool in this case, there's two entities next side by side. You have classic type LCIS and you have pleomorphic LCIS, which look like DCIS. And let's look at the ER for that specimen. And most I'll show you the fun stuff. We already established it is. Let me find the ER. Yeah, here, look at the ER. Here, our classic type LCIS, which is ER positive, which is how it should be. And next to it, this pleomorphic LCIS is ER negative, which also makes sense. That's how usually pleomorphic LCIS is receptor negative. But most important, pleomorphic LCIS and also pleomorphic variant of invasive lobular carcinoma, often HER2 positive. And the danger of these cases, and I've seen, look at this. Classic type LCS HER2 negative, however, pleomorphic LCS is HER2 positive. And why those cases actually so confusing, not only when that entity colonizes, and that's similar cases, I had similar multiple cases like that. If this colonizes or some cancerization of lobules or colonizes, for example, adenosis or glands in the radial scar without P63, you may actually misdiagnose it as invasive ductal which is will be HER2 positive. But this is inside a lesion, which is receptor negative HER2 positive. And so it's very cool side by side classic type LCIS, which is ERPR positive, HER2 negative, plus next to it high grade LCIS, which is ERPR negative and HER2 positive. So yeah, and it has common necrosis, classifications, all the good stuff. And yeah, so yeah, so there's a bunch of cases. I have more cases, but I don't think we on time. Anybody? We almost an hour. Anybody have questions?
Yeah, that's great. Any questions people want to bring up before we wrap up? These have been really good, Alex. Thank you.
No problem. I have one mega case, but it'll probably take a half an hour to talk about that. I have a case, we should probably spend an hour, just a whole session, just talk about one case, but probably won't have time.
Yeah, yeah,
This
we
is
all
still
have.
very, I intentionally picked those very, very mind-boggling, provocative gray zone cases where it's really hard to make a call and not necessarily fit, especially this basaloid thing, which is we suspect to be solid basaloid variant of an carcinoma, which some things don't really fit, and also this metaplastic carcinoma in a young person when you really need to make sure to like keratins and triple negatives. Those are gray zone in a way. I mean, that's what it is, but they require a lot of workup and make you very nervous because you need to be 100% sure. And consequences are serious because triple negative metaplastic carcinoma in young person will with high grade KI, high KI will result in chemotherapy. So you kind of need to be sure what you're talking about here. Yeah.
Yeah. Well, I don't see any questions coming up on the chat. Certainly, if people have questions, they can email those to me, and I could pass those along. But otherwise, thank you very much, Alex, for your
Well,
preparation
thank
and
you. Thank you. It was
presentation.
fun.
Yeah, this
Hopefully,
was a lot of fun to see. Some
yeah. And
very
again,
interesting, unusual
this is not
cases.
really knowledge based. It's more like you have to figure that out every time. And they don't have like a pattern. Oh, I know what it is. You cannot
Yeah.
approach case like that. Unfortunately, your approach case, I don't know anything what's going on. I need to do stains, and I'm not sure. And then based on stain show, you do that. You cannot really possibly say, "Oh, I know what's going on." You cannot possibly know. It's you need to figure that out.
And we'll put in the link for the video where they can buy your bread or your farm goods. Okay.
That's that's my
Okay.
that's my day job. Okay. All right.
All
Thank you
right.
very
Thanks
much.
so much, everyone.
Thank you. Thank you.